Okay, so we move to the next lecture from Dr. Cha Giang, Hanoi Hospital. So her topic will be complex PCI in de novo lesions with DCB experiences from Hanoi Hospital with case demonstration. So Dr. Yang, please.
Thank Dr. Wee for invited me here to sharing my experience when I use DCB for lab main bifurcation. So yesterday and today we have a lot of lecture about a lot of measure to deal with any complex lesion. And this case for relax today because thank for all of you stay here until now to join with us. So I go directly to my patient with male 44 years old, very young, with high risk is hypertension and dyslipidemia. The patient went to my hospital due to chest pain, CCS3. We check any showing as is normal, and we move the patient go to cath lab, and we check the coronary angiography patient. We see the lesion is near bifurcation, so only you can see in the CAG, see that the lesion in the artery of diagonal, we have a big diagonal, and the artery of LD extend to the left main maybe. Here you can see clearly. And after I have a funny story about the patient. After PCI for the patient is the first time you will see after stenting. It doesn't run. The patient has the same from left main to LED, provisional stent and checked by IVERT is quite good. And after that, I have discussion with family and the patient, and know that the patient a lot of things about always worry about something, always never sleep good or something like that. And I say to my colleagues that the patient will go as soon as possible because I know will this degenerate in stent or maybe even. And after 10 months, the patient go to other hospital due to chest pain with the diagnosis of the non-STEMI, and and they go to me and ask me to take care of patient because they don't want to deal with the lesion like that, and ask us to guarantee for the patient. So I receive the patient, go to my hospital and check again. You can see here, there are in the angio, you can see the degenerate in the arteriole exactly in the point of the lesion before until the detail of stent in the left main, and the new atherosclerosis plaque extend to the arteriole of diagonal and the circumflex, and you can see here. And this time with this patient, I don't want to put any more stenting for the patient, and I choose another approach. And I have a approach to do own DCB for the patient. But the question is that if we do the DCB for the patient, how we maintain the hemodynamic stability for the patient during DCB balloon implantation. We need to keep at least 30 seconds until 60 seconds because I don't want to make any more dangerous event for the patient again. And that I think I need to, for the left main to say it with the DCB with 4.50 mm DCB is good, and we have flow into the LED. But for the LED and the left main, the bigger balloon with the 4.0 mm balloon, we will occlude total, circumflex, LED, and diagonal. What's happened? And here is a IVOT of patient we check before we do procedure for the patient. You can see here is a newer soft atherosclerotic block formation. So you can see a very sharp block into in the stent, left main, LED, even extending to the artery of circumflex and diagonal. And in my lab, where I have perforation balloon to deal with some perforation with the balloon like that from Japan. Yeah, I have friends to give me some balloon like that. And I think that maybe I could use the balloon to protect the style brain during I implant the DCB balloon to prevent the economies for the patient. And how I do? Ping pong guiding technique I often use in my hospital to deal with some complex cases like that with the 7 friend and 6 friend. Because with the strap of the perfusion balloon, it's very stiff and bulky. And cutlery balloon I use with the size of 3.5 to open the left main stick and left main LED. And NC 4.0 for left main to LED. And the first balloon for left main DCB, left main to CX. And the second I use 4.0 30 mm with the I keep the second guiding IU perfusion balloon to CX and I protect the CX during inflation. And I extend the time up to 60 seconds. It's the normal exchange to the hemodynamic of the patient stable during implantation. And the DCP to left main to diagonal with the 3.0 at 7. And I kissing in a pair, and final I kissing LED, LCX, and diagonal. And here's the final result. I check IVOT is quite good as the artery of left main LD, left main LCX, and left main diagonal. And I explain why the patient come back to my hospital, and I ask them go to do something to relax. And the patient choose the meditation combined with any follow-up my hospital. And 1 month ago, the patient asked me to check the CIC of the patient again because the patient free from any chest pain, anything. But the patient changed a lot of his life, 100% from the before standing and after standing the second time. And I check after one year, the patient take meditation, and there's something like that. And the patient want to see IVOT of the patient again. And I check the patient is similar. It's not more progress of the new sclerosis blocker. And I think I have not only patient, a lot of patients like that. Many patients go to me a lot of time re-intervention, and I discuss with them, and I know many problem around the patient, not related to the disease, but many other in society. And I think the most important thing we need to control stress, because I know stress is the most important to increase the event cardiac for the patient, especially in the neo atherosclerotic blocker. Thank you.
Thank you very much, Dr. Giang.